Thank you all for coming. And the title of this session is Engaging the Vulnerable in the Quality Agenda. And before we get going, I'd like to say that I thank my two colleagues, because I'll forget to thank them later on, but most importantly to thank Stacey Johnson in the back for doing all the organization. We were saying right at the beginning, I've never been to a session where you're so well organized. Normally I show up and then they say, could you speak for 20 minutes, not 40 minutes? And by the way, the slide projector's not working, and nor does the loudspeaker or whatever. And so this is fantastic. So I have to thank Stacey and others for the organization. So engaging vulnerable populations in the quality agenda is something I think certainly all of us are passionate about, and I suspect all of you, but exceptionally challenging. So first of all, I'll introduce the presenters in a moment, but just to let you know, we have no commercial interests. Unfortunately, the session has received no commercial support, and we're meant to use tweets. I don't think I've ever used a tweet, but there you go. So the learning objectives of this session would be to actually engage you as an audience into discussion about exploring the principles and strategies on how to engage vulnerable populations to inform and design the delivery of care that suits them. And I'm going to talk about that in a minute by way of introduction. And learn how others are engaged in vulnerable populations. What lessons can we as communities of practice, people who deal with this on a regular basis, what lessons can we learn from each other and share to others so that we make this much more commonplace? So that's the hope. So these are what we're going to do is I'm going to give you a brief setting of the stage, if you will, and then we're going to have presentations from my colleagues and then myself about our experiences. And then we're going to try and engage you about some of the things that you do in your practice and what works, what doesn't work. So Sean Kidd is an assistant professor in the Department of Psychiatry and University of Toronto. He's the interim psychologist in chief at the Centre for Addiction and Mental Health. So welcome, Sean. Paulos Gabrisis is the Senior Director for Health Promotion and Community Services at Unison Health and Community Services. And I'm Jeff Turnbull, Health Quality Ontario. I'm all of Health Quality Ontario. Actually, I'm the clinical chief, the newly minted clinical chief, and what that means is I'm trying to figure out what I'm meant to be doing. I'm meant to be trying to work towards communities of practice and trying to see how we can engage different groups in the process. My other life, however, is that I'm the Chief of Staff at the Ottawa Hospital, but relevant today is I'm the Medical Director of Inner City Health. My clinical practice is poverty and health and the delivery of health services both in the developing world and the developed world. So that's by way of introduction. Here's the agenda. And I'm set the stage, if you'll allow me, to really say why is this issue important? Why should we try and engage these vulnerable populations, challenging populations? And the first one is that we've heard our healthcare system is unsustainable. We heard that even today. $200 billion per year, $6,000 per person, about 16.6% of our GDP, puts us, in terms of expenditures on health, about fifth of the developing world. So we're spending a lot of money on health services delivery. So it's not for lack of money, but its growth is about 7.5% until the last year or two. Now it's growing at around 3.2% in Ontario, tracking to get down around 2.5%. So we're still, I don't think, in all of my discussions at any time, most people don't say our problem is that we're not investing enough money in healthcare. I think we are. I don't think we need more money. I think we need to invest our existing money much more effectively. And so why is it unsustainable? Yes, growth of health services, but it's the quality agenda that makes it really unsustainable. The value for the money that we spend It's just not there. Canadians might accept the fact that we spend so much money on healthcare if we actually truly got one of the best healthcare systems in the world. But in fact, if you look at our comparators, we're middle of the pack to the lower 1/3 of OECD countries. So the lower 1/3 is in safety and the patient experience, and the patient experience, the biggest part of that is access. So we're tracking in about middle in many parameters to lower 1/3, yet at the same time we're spending a significant amount of money. And when you look at the value for money equation and you look at us in the Commonwealth Fund or the OECD funds studies, we're about last. If you put the Americans in there, we're second last. So that's our challenge. And so why would I be talking about that in the context of vulnerable populations? So we're going to have to fix the healthcare system with these challenges that are so very important. We've heard all about an aging population, the prominence of chronic diseases, increasing utilization, physical restraint, and classic federalism. So our healthcare system was growing until last year at around 7.5%. Aging population was 1% of that. Utilization, interestingly, age adjusted, the amount of drugs, the amount of tests, services provided per person, that's 2%. And frankly, I've been at this business long enough. I've seen my patients who are 88, 90 years old coming into the hospital on 20 different medications, having had ultrasounds, CTs, MRs, PET scans. And frankly, I don't think they're all that healthier than they were 20 years ago when we didn't have half of that. So utilization, we've got to change. But why would I talk about rising social inequity? What's that about? Well, the reason for talking about rising social inequity is that social inequity directly relates to health inequity. And if social inequity grows, health inequity goes. And in that context, that's an important problem for all of us. And rising social inequity and income disparity in Canada is rising faster than any other developed country in the world. We are winning the race to the bottom. So that is the challenge that we face. That's the challenge that all of us face on a regular basis as well as you do. So I'm just going to end in this section by saying that the implications for vulnerable populations, whether they be our Aboriginal community, the disabled, the mentally ill, the drug addicted, the poor, the young, the elderly, the refugees. The implications for those people are they experience health care different than the average person. They suffer because of their poverty or their vulnerability with their health. And I'll talk a little bit more about that, but the highest incidence of lung cancer in the world are Inuit population. The incidence of tuberculosis, higher in many of our reserves than they are where I work in rural Bangladesh. Incidence of HIV, some of the sub-Saharan, the epicenter, around 21%. My drug-addicted individuals in the shelters, 21%. Hepatitis C in those drug-using populations, 80%. So huge health disparities. And we said, we were so proud today, we reported that the average life expectancy of the population has gone up to 81.5 years. If you're in one of my shelters, you're not going to live beyond 25% will live to the age of 75. If you're in the richest part of Hamilton, you drive to the poorest part of Hamilton, life expectancy drops 21 years in that 15-minute drive. So we can talk about averages, but when you actually look up who makes up that average, there are vulnerable populations that are becoming more vulnerable, larger groups of people that we have an obligation to address. And the challenge is they're voiceless. They're difficult to address. They're difficult to approach. They want health care on their terms. And that's our challenge. This is not just a social, doing the right thing. It's costs us a great deal of money to ignore it. So the imperative here is that what we have to do is resolve this problem, even if you didn't think it was a good thing for society to address these vulnerable populations. We cannot afford financially not to, because we spend ineffective amounts of money, excessive amounts of money on this population with the wrong outcomes. So we have to rethink how we deliver care. And we can talk about that much more directly. So our challenge is to engage the voiceless, to consider who they are, to address healthcare on their terms, the healthcare they need, when they need it, and where they need it. It's not on our terms, it's their terms. So that's our challenge. So I'm going to stop at that as an introduction. We're going to hear 3 different approaches to that, and then we can open it up for your experience as well. Sean?
Thanks. Okay, well, I was very happy to be invited out to be a part of this conversation. And getting ready to come here and looking through the slides I sent out, I realized, as usual, I have too many slides and really almost too much content to describe what I think is actually a fairly straightforward project, maybe a little difficult to deliver on in terms of logistics, but the concept itself is pretty straightforward. This is a picture from a screen capture from One Flew Over the Cuckoo's Nest, which kind of illustrates part of the problem, I think. I'm not going to go through the cast of thousands involved in this work, but it did involve a number of the peer support workers at CAMH, some investigators, some clinicians, and we had some funding from the Canadian Foundation for Healthcare Improvement and as well as CAMH kicking in on it. So basically what this was about is in mental health. There's a movement that many of you are probably aware called mental health reform, which basically means moving on from custodial models of care that's really just dealing with risk and is dealing with medication and little else, and really focusing a lot more on holistic care that's geared towards people's own goals for their recovery, care that delivers outcomes like employment, like a meaningful life lived, and these sorts of elements. And it comes from a lot of different places, and it's a big conversation, but what it boils down to is our system historically has really underestimated the potential of people with more severe mental illnesses, and as well, in terms of the treatments that we've been providing aren't the most effective for taking schizophrenia, for example. The medications aren't the greatest, many side effects, and a lot of the treatments that we have don't have the impacts that they need to in terms of people getting on with life. So that's the movement that's happening, and there have been some inroads in outpatient care, so community-based care, but the sector that's been left behind in this conversation are the inpatient units. And the inpatient units are important because, as you see here, taking schizophrenia, for example, most end up in a hospital bed, spend a long time there, and are back at hospital many times. And along with the impacts on family and the loss of time in their own lives, you see the costs here, because half of all mental health and addictions dollars are spent in inpatient units. Yet a lot of this conversation about models of inpatient care, what's effective, what's not, getting on the mental health reform agenda just hasn't happened. So that's where we came in, and the context, I guess, of the inpatient units, when you look at it, it's really about clinician-driven decision-making for the most part, managing risk. Clinicians often don't understand or don't have a handle on where they fit in the scheme of moving mental health reform forward. And there's this phenomenon I can call or consider inpatient myopia, where, of course, when you see people only when they're in crisis, and the moment they're starting to do better, they leave, you can begin to get in the mindset that that's all there is, that what you see on the inpatient ward, this is people's lives, when that's actually quite inaccurate. So the question is, of course, well, what can we do about it? And what healthcare systems and services tend to do is roll out the PowerPoint. And these one-off PowerPoint presentations about how to do things are soundly ineffective for the most part. So we wanted to do something a little bit different. This was emphasized in particular because we were going through accreditation at the time, where I think, that was a lot of PowerPoint. But the idea is pretty straightforward. What needs to happen is, we thought, we find some folks who've been on our own inpatient units in the past, people with a diagnosis of schizophrenia, find a range of folks, a diversity of people across gender, ethnicity, the places their illness have taken them, and people have gotten on well in life, have gone to grad school, had kids, are involved in their church, are volunteering, a range of folks, and bring those stories and that contact, because contact, of course, is what moves things forward, bring those stories onto the wards and engage providers about what works, what doesn't, and this is my recovery story as opposed to my story about when I became unwell and what happened then. and to facilitate it. And where we engage a number of communities here, service providers, administrators, and we also engage the KMH Empowerment Council, which is a advocacy organization for people with mental illness, affected by mental illness. And they were as behind a randomized trial design as I was, actually, because as a researcher, I always think about these kinds of things. But what their interest in it was looking at effectiveness, because there's concern that too often people with lived experience are brought up to talk about their experience in a decontextualized way in which the impacts are up in the air, no one knows. And so the idea is that if you're asking people to bare their soul, to put themselves out there like that, there's got to be an impact. Something's got to be delivered at the end of it. And RCT is a decent way of doing that. So what we did was randomize 3 of our inpatient units to getting talks twice monthly for a year. This is just a diagram laying that out. 3 inpatient units matched roughly on how they operated were the control group, the control units. And we measured at the beginning and end of a year to see what happened, what were the impacts of having folks come back to the wards and give talks about their experience. It's got a small excerpt from one of the speakers' talks, but we had a diversity of stories. We had some folks that had nothing but good things to say about their experience in the wards at CAMH. We had some folks that talked about extremely negative experiences, and they would describe their experience, the recovery experience, the position of inpatient hospitalization therein. So for some it was helpful, for some it was something to be survived and gotten away from, and then where their lives took them, and they gave some constructive feedback about care on the units. And all of our speakers went through a lot of training, a lot of support in developing an effective short talk and in terms of giving constructive feedback. So what did we find in terms of what the numbers told us? We found there's a lot of stuff, sort of researchy stuff here, but basically it boiled down to we found that people's attitudes and values about how they engage folks on the inpatient unit had changed. People were seeing people more holistically. People were recognizing that there isn't a lockstep progress through recovery where you need to get your symptoms completely resolved and then have a conversation about employment. For many people, the symptoms don't totally resolve, so that can be waiting for forever potentially. So things like that. People came to a bit of a different perspective. Our effect size, not too shabby. 0.68 is a lot better than CBT for depression, just to give you something to compare by. So something happened there. That was encouraging. We didn't see change in what people did. Not too surprising, because what this was about really was engaging people around attitudes and values and perspectives. We weren't talking about how to do things differently, which I'm going to get to in a second. So what were the qualitative themes? We, of course, spoke with staff about what it was like being a part of this. Many spoke about being much more hopeful. It was this inpatient myopia thing. It was really great to see the folks that had been on their own wards, where they got into in life and understanding where they fit in that picture. They felt like their work was more meaningful a little bit. They might spend most of their time feeling like they're putting out fires and dealing with crises, but really kind of seeing themselves as a part of a larger picture and felt like more motivated and better able to engage clients. Really, there was another piece here as well. There's what's it called? It's initiativitis or initiative overload. I think it affects all of us working in hospitals. But many feel like these sorts of conversations about recovery-oriented care and so on, people can feel like, oh God, here's another thing I have to do on top of all the other damn things I have to do in the day. But really, what our speakers were talking about was just some basic respect about the small elements of engagement that make a difference. That was a large part of it. So I think people liked hearing that. And a few talked about calling fewer code whites, calling security less often, because if someone's coming to a nursing station, you acknowledge the person, say, really busy right now, give me a minute or two and I'll get back to you. A little bit of that versus the back not turning. These sorts of things, people get less frustrated. And I could certainly relate to that, trying to get the staff off the unit to come and to take part in these talks at times when you're standing there trying to collect people who can experience that frustration. So they spoke about that. So what were the implications? What did this project effectively tell us? I guess the first piece was giving some evidence to the idea that engaging with people with lived experience, it does make a difference. Really, I think the other piece that we need to start thinking about is how to position this in a larger frame. So that's what we're doing right now. We're rolling out a Care Pathways initiative where people, it's intended that people will come onto an inpatient unit, maybe from an ER, from another referral, get an assessment done, be offered programming that's relevant to them as a person, and begin to engage in interventions that are a bit different than the way units have operated historically. But to get providers in the headspace as to why this is relevant and important, you need things like the speaker series at the front end. side. And where we took it as well is, and this is something that again, there will hopefully be some opportunities to share with you, is we engaged, it's my Scottish heritage, I suppose, but I always have a bit of money left over at the end of grants because I'm cheap. But at the end I had $4,000 or $5,000, and we engaged Workman Arts. It's an arts organization oriented towards people who are affected by mental illness. And what they did was took the concept of these talks and asked them, could you make a film of this? Why not? And so, film of people giving talks is extremely boring. So what they did was create a concept whereby there was some protagonists on one of the empty units at CAMH who, there's a nurse and a client, and the usual sorts of conflicts that happen about not being engaged properly, why didn't you sign in, this sort of stuff. And then they ended at the end of it stuck on an elevator together, the two of them. Her cell phone's not working, and they're stuck there, and they're forced to have this different kind of conversation about who they are as people, and then walk off different people. I thought it was kind of an artful way of doing that, but hopefully you'll get a chance to see that at some stage. So that's the paper that came out of this. But anyways, we were quite excited by it. It is rolling out. It's going to be a part of moving the care pathways piece forward at CAMH. Ontario Shores is interested, so we are hoping that this model can be packaged for people's own sites and taken on. All right, thank you.
Okay, good afternoon, everyone. Tough gig following these two great speakers, but I'm happy to be here to share with you a little bit of our experience at Unison with regard to engaging vulnerable populations. And got it. Thank you. Okay, so I'm with Unison Health and Community Services, and I'm going to speak to you a little bit about a partnership that is ongoing with CAMH, actually, with the Center for Addiction and Mental Health. And again, some acknowledgements. It's a fairly lengthy program that included 3 community health centers in Toronto, South Riverdale, CHC, Central Toronto CHC, and Unison in partnership with CAMH. And the focus was really to try and address stigma with people who are consumer survivors. And so why did we sign on? Why did we even take on this project? We're already doing so much around vulnerable populations. There's a whole range of work that we do at community health centers. But one of the things that we realized was that actually stigma is often strongest in primary care and primary healthcare settings, even more so oftentimes than out in the community. We also recognize that we have a responsibility to optimize and improve the quality of our primary health care because we do so much work around the social determinants of health. We're often working with the most vulnerable populations within our community in Northwest Toronto, in particular certain ethnocultural groups, newcomers, refugees. And the organization has a little bit of experience with capacity building in low-income, low-resource settings. And lastly, a few of us at Unison really felt the need for this kind of intervention. We felt that it was needed given the dynamics that are happening in our organization, and we wanted to address it. If you don't already know, most community health centers often have a community health or health promotion wing as well as a primary care practice. And one of the challenges in post-merger Unison as we grew in size was while we have a very wide range of programs and services across the organization, we're not often as integrated as we would like. And so we wanted to address some of the stigma that we felt was occurring in programs and services within the organization where staff do not have the same kinds of relationships that those who are more community-based are. So this was really important for us. We have this, we have our vision of healthy communities. Our mission says to work together to deliver accessible and high-quality health community services that are integrated, respond to needs, build on strengths, and inspire changes. So that really pushed us to take this on. And so we took this on with CAMH and with the other partners, one, to better understand how stigma and discrimination looks like in Unison, as well as other community health centers, in particular around mental health and substance use, to develop some sort of intervention that really addresses the needs of the communities we serve, to try and pilot test an intervention, and then hopefully to share the results of that with folks like yourself. So just a really quick timeline of the project. It's a multi-year project, started in late 2010, and we're now about 2.5, 3 years into the project. And I wanted to talk today really to emphasize the contact-based education component of this partnership. And so what we wanted to do was to create a space in the community health center that's welcoming and accessible. We wanted to expand our harm reduction services, and we have already a core harm reduction program that does street outreach, needle exchange, peer programs. But again, this is not something that the entire organization had bought into or was practicing. And so we needed this additional partnership and this initiative to try and engage the entire staff team around these concerns. We developed an advisory team across the organizations, and then we wanted to reinforce our own values to work with consumer survivors and align our own strategic direction. So we said, okay, we'll have to do a bit of training and knowledge exchange to develop an advisory, and also to do some promotion and communication across the organization and really look at our structure, services, and processes. Well, what did that require from us? It really forced us to confront the stigma and discrimination that occurs within our own organizations. As proud as we are of our long history of being a community health center and being accessible and addressing those social determinants of health, we have to recognize that we're part of that healthcare system and that stigma does exist in our organization. We had to really go and find some new resources, some new partnerships to get some support for that. And there was quite a bit of defensiveness, I'll be honest. And it was different. There was some resistance from managers who felt, I've got, I think Sean referred to it as initiative-itis. I've got 100 things to take care of. I've got my performance framework to address. I've got my clinicians to ensure that clients are accessing services. And so they didn't really understand this anti-stigma. It seemed a little bit, it's not clinical, it's not concrete. And the providers who felt a little bit defensive, saying, "What, am I doing something wrong? I thought I was great." And so we really had to work with the staff team, both with managers and with the staff, to say, this is about enhancing and improving. This is not about judging. And so it took quite a while, actually, to move this through the organization. And a part of what we did in order to move it forward was to develop this interdisciplinary mental health task force that was going to take the lead and really took it to the management team for discussion. And at the end, we made a decision to close the entire organization for a full day and dedicate it to this one day of training. Well, so this really was something that we wanted all staff to be a part of, and we wanted to bring consumer survivors to meet with and be the trainers. And so our staff were now on the receiving end of information when they're often accustomed to delivering information. There was role play, there was a whole range of things, and my slides are really busy. I'm sure you will get a copy of them. But the whole point was just to really create this whole dynamic. We did our pre and post, and there was some interesting information, although it wasn't so significant. This wasn't really about skills development. This was about reorienting people to acknowledge that folks who often come in crisis, who are often labeled as people who have drug addictions or mental health issues or are disruptive, also actually have the capacity to come in and train and present to a team of professionals. So more researchy stats there for those of you who are interested. And so our next move moving forward is, again, to engage. We've invited staff to join with consumer survivors. They're actually currently working on an arts program to have the folks that work with us illustrate for us what does it feel like when there's stigma present? What does it feel like when stigma is not present? And so we will be, that art group made up of both staff and consumer survivors will be presenting to our staff conference coming up in January, and I'm really looking forward to the discussions that actually will come out of that process and serve as a longer term reminder of our commitment to meeting the needs of consumer survivors. Okay, and I think that's really all I wanted to share today. Thank you.
Thank you. That's great. Thank you, Sean, and thank you, Paulus. So now I'll tell you about my initiative, or not my initiative that I'm fortunate to be part of. It's led actually by the homeless. And the rest of us support them in their efforts. Many of you have contact with what life is like if you happen to be homeless, hopefully not directly, but through your practices. Certainly some of the talks already have focused on profound complications associated with mental health issues and addictions. I characterize this as an environment characterized by alternating between crisis and chaos. And as you know, the homeless fundamentally move from crisis to crisis. Their mindset is very different. It evolves primarily around their addiction and mental illness. So their day is based on waking up in the morning. What am I going to do next to get money so that I can address my addiction, and then how is this cycle going to continue again throughout the day, and then where am I going to sleep? But the one thing that separates the homeless that I work with generally from the rest of the population is if you ask them, what will you be doing tomorrow? They look at you like, are you crazy? But if you asked any of you, you would know what you're going to do tomorrow. You have a 3-year plan, a 5-year plan, whatever. They have a 24-hour plan. And it is fundamentally, I'm going to do the same thing as I just did today. So who are the homeless? Basically, this is over the last year. This is our population that I deal with, provide services for. You can see the breakdown there. I won't go into that, but just tell you that women have become much more prominent since I started in the homeless community over 15 years ago. I see now more families and women, and now we have this burgeoning group of youth, which I'll describe for you. First, the adult male population. Generally, that was the population I began with. These were the people who were alcoholics, street involved. They've been on the streets for 20, 25 years, refractory alcoholics, and had moved from wine, the winos we don't see. We see Purell, Listerine, paint thinner, sometimes gasoline. That's the people who are profoundly addicted in my setting. However, we've seen more women, and they have many very challenging issues, what I'll describe in a minute. But we have 1,000 every night in Ottawa. You don't in the winters in Ottawa. There's no great system or subway system, so we know who they are, where they are. They're ours, and they're all entered into some form of a shelter, and if they're not there and it's cold, we go and find them. Youth, interestingly, we've seen this population of youth grow, and the youth, they're highly mobile. They're the couch surfers, if you will. They move from up the valley where they're fled circumstances of abuse or family discord of some form or another, came to Ottawa, and we're going to spend some time with a friend, and then that time passed, they couch surfed for a while, and then they found themselves into the shelter. And youth, if you don't get somebody who's 15 years old out of the shelter environment within 6 months, they're going to be there forever. A young 15-year-old in the shelter environment will be soon addicted, and only way to support that will be through street work. When they have hepatitis C and HIV, they're not going back to Pembroke. So our challenge is to identify them early and get them into meaningful other activities such as schooling, and sometimes back to Pembroke, but not often, I have to say. We try and, because there are so many conflicts and challenges there, that we try and divert them. Families, easy group. If you can just invest in families, I suspect all of you recognize this. These are people, intact families. If you can get those people the necessary resources that they need, they'll get on with their lives very quickly, and you won't see them again. Women, challenging group, proportionately smaller. They're often addressing issues of not only substance abuse and mental illness, but abuse in their history. Often have children, often have had those children taken away from them. And one thing you can tell about all my ladies who are street workers, they all have when they're having a bad day, it's generally because that's the birthday of one of their children. And they all, I don't know if you'd all recognize this, by and large have a little doll or something like that where they're in their bed, in their room. And, you know, they're tough, but actually there's opportunities to make very substantive inroads. And then, of course, we have the mentally ill. The very significant proportion of my patients are mentally ill with drug and alcohol addiction. And we used to think that that was a 21-day program. Now we've recognized that's a 10-year treatment program. Now with functional MRI, we know that this is a long-standing, complicated road to recovery. And the longer you're addicted, the longer your mental health is there with you untreated, the more challenging it's going to be as you become entrenched into the environment of the street. So what does that do? As I mentioned some things about health, I thought I was going to go down to these shelters and some 15 years ago and just hand out some antibiotics, treat a bit of TB and HIV, and then I would head out and that would be great. But then I found out I couldn't do that unless I got control of their addiction. And I probably couldn't get control of their addiction until I addressed the mental health issues, and you couldn't do any of that until they were housed. And that was the dilemma that I faced. And I told you about some of the statistics of my homeless environment, but generally when we survey that population, they have about a 4 times mortality rate than the housed population. I told you about HIV, hepatitis C, 80% of my injection drug users. That whole community changes on a regular basis. Their mortality changes dramatically, opportunities for improvement, but we react to the addiction du jour. So when it was alcohol, we were reacting to alcohol, then crack cocaine and prescription opioids, now heroin, and we react on a regular basis trying to get ahead of that. So that had a huge burden on the healthcare system and the burden on those individuals. And I said that this was ineffective and costly healthcare. The average person, about $170,000 per person per year of my chronically homeless people. That's the cost of fire, 911, hospital. And are they getting fantastic care? No. So we're expending a lot of money and we're not getting very good outcomes. The challenges for us as we address them that may not be forthcoming about their poverty, follow-up is a challenge. We're trying to fit them into our schedule when they have their own schedule. And everything takes more time with this group. There are obstacles to the care. When we actually went out to the community, we kind of thought that we had the problem solved, what we were going to do, and then we asked them. And they said, that's not what we want. Are you kidding? What we want is transportation. We need to get access to our medications. We don't even have drug cards. We're worried about stigma. The whole issue of medications and diversion of narcotics. Education, healthy, they want not to be judged, and their concept of health was exquisitely different than what our concept of health was. And we had to refigure that whole thing. So we had to build trust, develop care on their terms, supportive housing, intensive case management, and sustained interventions, and be prepared for failure. And that's, we sort of girded our groins and off we went. And so this is what we ended up with. We started off over 10 years ago, and we were around 40 beds at that time, and now these are our partners within the organizations. They're members of our board. So suddenly I'm dealing with people that I've never been used to dealing with. I'm used to dealing with hospitals, and now I'm dealing with religious organizations. I spend more time with the police than I do, and judges, than I do with other providers in the hospital. And so we have to have new friends, new partners, and that was the lesson that we had to learn. We've grown, and the program it's an integrated health system for the homeless. We provide services, hospital-based services, palliative services, health promotion services. We do the immunizations, we do baby checks, we do everything. But we do that in the shelters on their terms. We don't expect them to go to the hospital. And we especially don't want them to be picked up by the police for intoxication, fire, 911, off to the lockup or to the emergency department. You can see there we have a hospice, we have a special care unit for men and women that is very much like a hospital system. I do IVs, oxygen, I administer medications, I find people under bridges in fields, and we're all over. This is an army of people. When I say it's not me. Just to show you this, we have probably 70 personal support workers. We have 12 nurses, 2 nurse practitioners, and we have 1 doctor. And we get, with that, you can see the services provided. It's the size of a small hospital. And we provide all ranges. We have speaking of harm reduction, we have a managed alcohol program, needle exchanges, etc. The guys, when we listened to them, they started to say, look, we don't like the way you're organizing things. You're too nice to us. We need some structure here. We need a mayor. So they've said, knock yourself out, guys. Vote in your own mayor. They did. The mayor runs the place. And so we gave them control. Now, these were inveterate alcoholics, homeless people, drug users. They're taking control of their lives. They then said, we don't like being downtown. It's amongst all these drug addicts and alcoholics. They're still drinking in our programs. We give managed alcohol. We give 1 drink of alcohol per hour, starting at about 8 in the morning and finishing at 9:30 at night. You say, wow, that's a lot of alcohol. That's 1/9 of what they're drinking on the streets. And once you take away the craziness of their lives by administering alcohol, they start to think about, well, I'd like to get my family back involved in my life. I'd like to have Christmas. I'd like to plan for Halloween. I'd like to come up to your farm, I live in a farm, and cut a Christmas tree. Chainsaw with the homeless guys. You gotta be crazy. At any rate, it works out. And then they said, we want a house of our own. So we bought the Oaks. And the Oaks is an apartment. We have 55 units there where they live independently, running it themselves. We help them out, but that's where they are. And then we noticed that many of our people were ending up in the emergency department. So we have a targeted engagement and diversion program where we actually go out and proactively find those people who are in the emergency department or contact with the police, and we bring them into us. This is my last slide, just to show you that we've had failures, we've had successes, we've had marriages, we've had funerals. We found one person who, this guy with a beard on the side there, he was naked on King Edward, dying of HIV. We put him into the palliative care unit, but in fact, we treated his biliary tuberculosis that he had and his HIV, and we said, Normie, you're not dying, you've got to leave. And he said, no way, this is the only place that I've had where people will look after me. So we said, Normie, we'll continue to look after you, we'll put you up on the 5th floor. And he said, but I'm so bored, and I like to paint. And we said, okay, Normie, I'll give you some crayons and a pad of paper. Well, Normie went with me to a local paint store and bought about $150 worth of acrylics, and he said, I'll paint you something just like I have in the National Gallery. note to self, changed Normie's medications. He's obviously, he has 2 paintings in the National Gallery, he has a coffee table book. So you meet these wonderful people. He's into needlework, and that's his one of his needleworks there. So the net result is, what we've found is that if you listen to this population, if you provide care to that population on their terms, and you're willing to accept failure, and you're willing to be flexible, and you're willing to break out of the norm, and the net result is you'll get better outcomes. So in all of our parameters, we had better self-care outcomes, we had compliance issues better than the housed populations, standards of acceptable care better than the housed populations, and we saved $3.5 million net of our expenses. Better outcomes, better care. So it can be done if you listen. So that was our experience. What we'd like to do now, in the time that we have, if you'll allow us, our timekeeper is keeping us really to a tight rein. We'd love to hear from your comments. We'd love to try and answer any questions and hear about your successes and failures. And then we have one slide, I think, right at the end, sort of summarizes some of our take-homes. So, to you.
Hi guys. I'm Anthony Mohammed, Senior Specialist on Equity and Community Engagement at St. Michael's Hospital. And one of the challenges that we're facing currently...
Can people hear, or will we have to?
See the microphone.
Yeah, there's a mic here and a mic over there, if you'll forgive us.
Sorry, I didn't see the mic earlier. Hi, everyone. I'm Anthony Mohammed, Senior Specialist Equity and Community Engagement for the Inner City Health Program at St. Michael's Hospital. The reason why I'm one of the challenges that we're facing is we have a number of community advisory panels currently related to mental health and addictions, homelessness and underhoused, women and children at risk, and who am I missing? Oh my goodness, it's off the top of my head. Anyway, the reason why I'm asking is because we're struggling with the model that we currently have. Right now we have community agencies, people with lived experience as well as patients, and then a range of hospital staff. That model has been very effective for the last 20 years I've been involved with it. However, times are changing, and it seems like people are coming and they're we have a format of a presentation and then a discussion about community trends, etc. So I understand the listening part. I'm just wondering about how we can make community advisory panels more effective. So I'll throw that.
I think, Paulos, we'll start with you.
Okay.
The good thing about a moderator is you don't have to answer any questions.
I think that's a really great question, and I don't doubt that many of us are struggling with that kind of a challenge. I don't know if there's any one particular model that's going to necessarily work. I think sometimes the challenge is you've got folks that have been on there for 15 years. So it's really hard to figure that out. And find something that works. I know at Unison we sort of put that aside at times, and we've gone for these much larger events where we invite a much broader set of community stakeholders and try and get some information from them, not necessarily the same reference group that we continue to go back. I guess I would say what our community health planner would say, which is a mix of methods, not to rely on any one particular strategy for trying to stay connected, with the community that you're trying to listen to.
Yeah, I guess I've had mixed experience. I've been involved in some projects with advisory groups that have been helpful, worked well. Others where it sort of feels like we're going through some kind of a play together that we've agreed to be a part of. I think that's been there, but I've found it much more rewarding to engage in projects. We've got people who might otherwise be in an advisory council or co-authors on papers. We pick specific pieces of work, carve out roles, and do things together a bit more actively. I find that's a lot more effective than kind of me doing things or clinicians doing things and then bringing it to an advisory, trying to sum up, and there's often these sort of decontextualized conversations and a lot of catching up and things. So I found a bit of a mix of both, but really my bias is towards engaging people that have a great perspective, a helpful perspective, and then we all do something in a project together and everyone walks away appropriately acknowledged in that. But
Did that help him? Yeah.
Can I just add one more? The other thing that I found is that oftentimes we set up these advisory committees to fit our structure perfectly. It's broad enough to cover a range of things, and it looks lovely on paper from our perspective. But from the perspective of community members, is it relevant? Is it actually getting them the things that they need to get done? And so sometimes when it becomes really focused and really concrete and perhaps even short term, we tend to find a little bit of a higher level of engagement and ownership of the process. And throughout, I think there needs to be a real sense that we're the ones who are accountable for the outcomes of that whole process as well.
I think the big experience that I've seen about community discussions, engagement, is that we listened, but we didn't really listen. It was thank you very much, and we'll go ahead and do what we're doing. And that's very disengaging if you happen to be on the receiving side of that. That's what I've heard. Sorry.
Hi, my name is Linda Robb Lenterman, and I'm the project coordinator and a registered nurse with the Kingston Health Link. And we work with 9 primary care organizations, so Feeks, Foles, and Fitz, and a community health center. And there was a lot of assumptions when I took the job, like I report to a steering committee, how, some primary care organizations deal with social determinants better than others. And I've seen patients, I do these complex patients, and what was interesting is across all primary care organizations, they are dealing with social determinants and they don't necessarily know. What I found interesting, the primary care physicians and the nurses, et cetera, do not know how to navigate to get the patients the care they need. And so on our preliminary data so far, the top 3 issues we've been dealing with is housing, income security, and transportation. Like a family doctor called me and said, Linda, I've got this homeless 32-year-old veteran with 2 kids, 2 cats, and his wife. Can you help me out? And so what's really wonderful about our Health Link, I'm very proud, is that we have what we call practical assistant worker, social services worker. And so the nurse and this person are a team. And the other observation, so my main observation is primary care, they don't know how to navigate. And I've certainly learned a lot. But my other observation is, what was it? I just kind of had this memory loss. I find patients that have mental health issues that don't have an actual diagnosis, people don't know what to do with them, and they bounce back and forth, and it's really sad. But what we've been able to do is bring different sectors together. I mean, this mental health young woman sees a psychiatrist every month, has the ACT team every week, numerous phone calls with the ACT team, sees her family physician every week, and no one ever talked before. And so we're trying to bring the different sectors together because they're practicing in silos. Any comments?
Just write down your bailiwick.
Sure. I guess, and maybe I'll just, because I'm kind of a project obsessed person, I suppose, but is we've got a piece of work happening right now. It's called the Welcome Basket Project CAMH, basically addressing, speaking of different areas or focuses of care, is the transition from long inpatient hospitalizations to outpatient care. Of course, most of us know that month is pretty critical in terms of suicide and getting readmitted to hospital. So we have peer support workers, people with lived experience who are paid employees of the hospital. They meet folks in the last couple of weeks of their stay before discharge, talk with them about what's going to happen. They've got a small budget to assemble a welcome basket of the stuff they might need. It might be a curtain rod, it might be an album, it might be milk and juice. They meet them at home and spend about a month with the person, helping them become engaged with their community if they don't know how to get to their case manager. I mean, these various pieces. So just speaking on the patient engagement side of things, it's a role that I don't know that someone without lived experience would do remotely as well in terms of engaging people with community, working across those sectors, and the providers, inpatient, outpatient, and certainly the people who are engaged in this have found it tremendously valuable at making the connections. And I think out of the 25 or so folks that we've engaged in the last year, only one's been back to hospital. It's not a randomized trial, but it seems to be successful so far. So,
Any other comments?
Yeah, sure. This is a very, very common situation for the work that we do at Unison, and I see some folks from the community health center sector here as well. So we've actually tried to address those things by creating all of those services within one governance structure, within one organization. So there is, for example, at Unison, a Streets to Homes program that has a team of follow-up workers that ensure people remain housed once they're housed. There's case coordinators who do ODSP appeals and systems navigation through various government supports. We've got social workers that might do some counseling. There's the street outreach. There's a whole range of programs and services that we try and offer those that need it. The challenges remain that primary care, as opposed to what we would define as primary health care, that whole range and continuum of care, are not supported in the same way nor by the same agencies. So for example, all of our primary care is funded through the TC Lin, Ministry of Health and Long-Term Care. Everything else has to be really gathered around from a whole range of other funders. So we've got, I think, a portfolio of 19 different funding programs in order to try and build a set of services that fit the need of the communities that we serve. This is not an easy task, in particular when each of those 19 funders have their own defined objectives, criteria for eligibility, etc. And so it requires a lot of creativity and a lot of determination, a lot of passion to try and rebuild together at a local community level a really broken and sort of over-distributed sort of system and environment for us to operate in.
So I think the question that you raise is a very, very valuable one. One is there are actually community resources out there. We just don't know about them, we don't access them, and they don't talk to each other. Yeah. So some kind of there are gaps clearly. There's no question. For us, it's supportive housing is 5 years. That's useless for me. But there are gaps, but nevertheless, we don't even use the resources we do have.
My name is Jennifer, and I'm a health planner at an Ottawa CHC. I'd like to get your observations on two issues in dealing with vulnerable populations. Health Quality Ontario, and before that, we've been surveying our clients for as long as I've been there, have mandated certain questions. The questions that they've mandated I suspect are just not culturally relevant for a wide variety of people. For example, we have a large number of Chinese individuals. I've been looking at results for 8 years. They're totally positive all the time. So what this means in practicality is, of course, we're in the test, but it means that for about 25 to 30% of our clients, and they could come from a range of different cultures, we aren't getting as good client experience data. And now that we have to report it, and it has to be, it's transparent to everyone, I'm very uncomfortable about not having 25 to 30% of our clients, and it's a range of different cultures. So that's one thing. And second of all, it's also about power differentials and any hints you have about this problem. I'm fortunate enough to be the internal evaluator of our harm reduction programs. And what we do is we interview a certain number every month or every so often on the quality of our services. The last time we interviewed people, because they're so anxious that the service will be removed, it's very difficult for us. I mean, we survey them, but I'm sometimes again wondering whether if they had an issue with the quality of service that we provide, they would forward it. And so your thoughts on those two issues would be great.
So let me try and do the health quality one, and well, my two colleagues think about the second question relating to power differential. When we collect data and give data back to province-wide down to LIN-wide data, it's average aggregate data. And when you look at, and it's sort of an average, so let's take 81.5 years on average, but that tells you a small part of the story. It's like this. But what was it like, what happens if that average was like this? Who sits out in the tail? And our metrics in looking for many of these important things do not collect who's out in the tail. So we should be starting, I think, starting to look at the tails and just say, does the average really tell the story? Or are we having such wide diversity in life expectancy, I'm just using that one as a metric, that we need to drill down much more specifically as to where we're noticing differences within that average. That's the one thing. Second one is that the people we serve aren't out there providing data for us. And so, just as you said, there are culturally inappropriate surveys sometimes. The average literacy rate amongst our populations that you deal with would be a lot less than the average population. So our guys are not out there filling out surveys, and they're not being captured in some of that. So even if you did capture them, they would be out in that tail and we'd miss them in the average, but we're not even asking. So we need culturally appropriate testing techniques that can actually sense and pick up discrepancies across populations. Within your population, I'll bet your CHC, there are subpopulations, and you've referred to your different ethnocultural populations. There are enormous variations just by driving from one end of a LIN to another, or to a city to the other. And we miss that cultural mosaic, that difference in our sampling techniques. So great question, and we at HQO, I think, would love to start moving in that direction of trying to pick up that variability. Power differential in when you're trying to gather information to people, are they afraid, are they going to be forthright?
Yeah. Great questions. And I think we're all struggling with similar questions. And for myself, speaking as a non-clinician, I think I still see the notion of a quantitative tool to try and measure quality of services as being somewhat foreign and not very useful in many of the kinds of interactions and situations that the communities we serve are facing. So it comes back, and it's really more about our culture that's inappropriate in meeting the needs of the communities that we're mandated to serve. So that's a real challenge, and one of the things that we've tried to do as we do our ongoing quality improvement assessment at Unison is, one, to try to really recruit and support a team of surveyors that are reflective of the communities that we serve, rather than looking for a high technical standard of competence by those surveyors. Far more interested in ensuring that these are people that are able to engage our clients and service users in a less threatening manner, to try and minimize that power differential. I think it's still there, but I think we've certainly found a little bit more rich information. It requires a little bit more upfront investment in building the capacity of that group of surveyors and being really creative and intent on trying to actually measure the things that are difficult to measure.
Could we go here first and then we'll end with you? Just, I don't think
Sure.
you should
So
be standing
the
around
last
for
question
too
was a
long.
really good lead up to my question, actually. So I'm a general internist that practices at Toronto Western Hospital, where we have a very large immigrant population. And a lot of the work that I've done has focused on trying to give a voice to people who can communicate in English. And so I guess my question kind of leads up to a bit less of the data, but looking at more how in your work have you tried to engage individuals who we were saying give a voice to the voiceless, but who can actually communicate and who aren't necessarily the types of individuals who might end up being on the video, or who might end up participating in some of these projects.
Excellent question.
So I guess I touch on a few pieces. I think around language is certainly in any endeavor that we're involved in, as we try one way or another to get some translation. When we don't have budgets, we've got a long lineup of volunteers out the door at CAMH, and generally we can find someone that can speak at least one of the relevant languages. So we certainly do pay attention to that. I think. Sorry, I think I'll just stop there.
We're really pleased with the service that I think it's University Health Network that's put together for the TC Lynn with regard to telephone interpretation. That's been a great feature. Prior to that, we had our own interpreters bureau, where we were recruiting and training community members to act as interpreters and for folks who share their language or cultural identity. I think we're in Toronto. We see a very, very diverse, multilingual, multicultural community, and we continue to try and reflect that in our staff team, in those who we're recruiting as volunteers, as peer workers, as animators. So I think there's many layers of that question. I don't think there's any one solution to anything. It's trying to always be reminded that access is a crucial element of quality improvement, and that this is something that we're all obliged to continue to work on.
I think the bit before my thoughts flew away, it's something that you'll be, if you haven't experienced already, I imagine soon, is from some baby brain from a kid up last night. So the second part of your question there has to do with, I guess, thinking about the folks that are the hardest to reach. With schizophrenia, may be really lost in the delusions and they're not going to be in films and these sorts of things. I guess there's the time perspective, because there are a number of these folks that might be in that space where they can't communicate with the world, that a few years down the line they might be, and they might be in a decent spot to sort of reflect on things for the people that are in that zone. And as well, people in that middle ground, so they might not be all the way in the direction of some folks that just can or won't be engaged at some level, but at least can kind of speak that language, relate to a greater extent than I could. And so I guess just looking at some ways that you can approach people that in that particular time, they're not talking. So
Just be cautious again in terms of my population. Many of those people are there hiding. And so when I try and get a culturally sensitive interpreter, they don't want anything to do with that. And they're not going to be forthright in terms of the discussions. They may come from a different tribe, a different culture, even though they share the same language. And there's a lot of intricacies that I don't understand. I've tried to understand, but I just know that there is a challenge there. So just a caution. Last question, and then we're going to bring it to an end.
So I'll try to be quick. So my name is Jill Oliver, and I'm a community ethicist, and I work in long-term care homes in Brampton and Etobicoke. And one of the things that I do is I speak to people in long-term care who are often elderly, and find out what's important to them. And sometimes what's important to them is not being healthy, but it's something else. And so then I end up trying to advocate on their behalf for what it is that they want, what's important to them. And sometimes that becomes a discussion between the staff and the family, where, I'm trying to explain, but your mom doesn't want to follow that diet anymore. She wants the chocolate cake, or she understands the risks and that sort of thing. So when you had said that that the population you work with have a different concept of health, that I'm very familiar with that. And I'm okay with that. And so I was wondering, is their definition of health something you want to challenge or change, or is it something that you accept when you work with them?
So thank you, Jill. They sometimes, to be honest with you, I can't get out of my shoes, and most of the times I say, fine. If that's what your priority is, then I can understand it. But sometimes I find that is just so challenging for me. A 21-year-old who is, you absolutely know this is not the right thing for them. And maybe that's the parent in me, whatever. And I should be less judgmental. I should be saying, okay, if that's the direction. But it is so, when you see that so self-destructive behavior, and you know that person is on their route to kill themselves within a year, it's very hard to watch.
It is hard to watch, and I will tell the people I work with, I wish you would make a different decision, or that you wanted something different, but I understand that this is what you want, and I don't have to understand why it's important to you. I'll talk to them, make sure I really understand it, but so I was just wondering about that.
But and you say, do you're going to, if you do this, you're going to die soon. But I'm kind of filled with the richness of life, and that would be terrible for me. For them, they say, so what's so bad about that? Who wants to live this life I'm living now? And that's kind of sobering, and you have to go with it. Pretty hard to watch, though. I'm getting from the boss, who's been very good to us. So what we wanted to do is, this is the last slide, you'll be happy to know, and we just wanted to end by saying, when we talked amongst ourselves about what we were doing, there seemed to be some common reflections, and I think a lot of that's been reflected in your questions today, so that was really helpful. So meaningful engagement is done early, it has to be genuine, and done in a thoughtful, strategic way. You must listen. You must meet people where they are, from their context. Reframe the way we deliver care to accommodate the needs of other populations. It's not all about providing care on our terms for the average population. We're probably not too bad in that. Deliver care on their terms. Adjust the way we deliver care for the 5%. Not up to them to adjust the system. It's up to the system to adjust to them, and listen. The last one I think is very important. That you could not do the stuff I do without accepting risk on a regular, daily basis. Risk for failure, risk for your own liability, risk for your own personal safety sometimes. There are risks in everything we do. And we have to just accept that you're going to have to put up with those risks because it's the right thing to do. And so we'll end at that. Thank you all for your time, and you've all been very patient, and your comments have been wonderful. And thank you for everybody. And thank you for Stacey.